Right. Well, my pleasure to welcome back another good friend, Greg Riely. Dr. Greg Riely is a medical oncologist at Memorial Sloan Kettering Cancer Center in New York City. He currently serves as the vice chair of clinical research in the Department of Medicine. His areas of expertise include thoracic oncology, lung cancer, thymoma, and thymic carcinoma. He received his medical degree and PhD at Case Western Reserve University, followed by residency in internal medicine at New York Presbyterian Hospital at Weill Cornell Medical Center, completed a fellowship in medical oncology at Memorial Sloan Kettering Cancer Center, and his clinical research focuses on the treatment of patients with thymic tumors and non-small cell lung cancers with specific mutations. Welcome back, Greg. Happy to see you.
Thanks, Bernie. Great to be back in Omaha, if only virtually. All right, let me try to share. All right, is that sharing well? Okay, great. Thanks, everybody. My pleasure to update everybody on the top events from ASCO 2020. These are my disclosures. I do clinical research that's largely funded by industry funding to the institution. I receive no direct funding from any of the companies. So this is sort of what I'm going to talk about today. This is the highlights of ASCO, but I also threw in a few extra meetings as well. So you get a little bit broader picture of what we've seen new in lung cancer in the last year or so since I was last in Omaha. I'll begin by talking about some new, not particularly useful, but nice to know data in small cell lung cancer. We'll talk about the addition of a short course of chemotherapy to a combination immunotherapy for upfront treatment of patients with stage 4 non-small cell lung cancer who don't have an oncogenic driver. We'll talk about a few targetable oncogenic drivers, MET exon 14, RET, and HER2. And then finally, we'll close with a section on the use of EGFR targeted therapies in the adjuvant setting, which is a major turnabout from where we've typically used EGFR inhibitors. Largely, that's been in the metastatic setting. So we'll begin with small cell lung cancer. Really the paradigm for treatment of small cell lung cancer treatment has not changed in a long time up until 2018. For the longest time, we had platinum etoposide chemotherapy as initial treatment. After 4 to 6 cycles, we stopped. We waited till the cancer grew. And then at that point, we tried topotecan. Topotecan was generally considered to be a lousy drug with a response rate around 16% and median overall survivals that were short. Over the past 2 years, we've seen a lot of movement in small cell lung cancer, and I'll remind you of some of that now. So it begins really with the evaluation of checkpoint inhibitors in patients with small cell lung cancer. Sorry about the typo there. And this is the trial that made the major change, and this is a trial that looked at initial treatment of patients with extensive stage small cell lung cancer who had no prior chemotherapy. Patients were randomized to either the standard in green, the etoposide carboplatin, or the intervention here, which was etoposide carboplatin and atezolizumab. And of course, atezolizumab is an antibody that disrupts the PD-1, PD-L1 axis that we hear so much about nowadays. This is the progression-free survival curve from that trial. You see that those patients who received carboplatin, etoposide, and atezolizumab had an improved progression-free survival, albeit modest, improving the median from 4.3 to 5.2 months. There's much discussion about potentially a longer, quote, tail of the curve in terms of progression-free survival. When you look at it a year and a half or so, you see that there are more patients with atezolizumab still alive. But this is complicated by a relatively short follow-up of the overall course. Overall survival similarly is improved with the addition of atezolizumab to etoposide and carboplatin. You see improvements in overall survival with a hazard ratio of 0.7 and a small p-value. You see that the median overall survival improves by 2 months, from 10 months to 12.3 months. In the past year, we've also seen data with durvalumab, another antibody that can disrupt that PD-1, PD-L1 axis. And you see here the overall survival curve on the left and the progression-free survival curve on the right. Hazard ratio of 0.73 for overall survival, showing that, again, durvalumab, a different antibody, has the same effect as atezolizumab. So adding an anti-PD-1 or anti-PD-L1 antibody to platinum etoposide backbone can improve overall survival. At ASCO this year, we saw the first presentation of this data. Work was led by my colleague Charlie Rudin, and they looked at pembrolizumab. Pembrolizumab has been explored in non-small cell lung cancer a fair amount, and this is the first time we've seen data in combination with platinum etoposide for patients with extensive stage small cell lung cancer. We see essentially the same outcome that we saw with atezolizumab and durvalumab, with improvements in progression-free survival and overall survival, with hazard ratio a little bit, not quite as good, with hazard ratio for overall survival of 0.8. Although the p-value is relatively small here for a variety of reasons behind clinical trial design, this was not a positive trial. And as a consequence, this won't be an option for use in patients with extensive stage small cell lung cancer. But since ASCO, we have seen another big movement in the world of small cell lung cancer. Just earlier this week, we saw approval of lurbinectedin for patients with extensive stage small cell lung cancer. I thought I would take this opportunity to just briefly mention the data upon which this FDA approval was based. So this is a trial that looked at lurbinectedin as second-line treatment for patients with small cell lung cancer. So patients all got a platinum etoposide. This is in the pre-immunotherapy era, so patients had not received atezolizumab or durvalumab. Upon progression, patients then received lurbinectedin. Lurbinectedin is described as a selective inhibitor of oncogenic transcription. This is a natural product from the Caribbean sea squirt. Thought that little bit of trivia might make this slightly more entertaining. But nonetheless, all patients in this trial got lurbinectedin. This is a single-arm study, not a randomized study. These are the outcomes that we saw for lurbinectedin in second-line therapy for patients with extensive stage small cell lung cancer. The overall response rate in all patients was 35%, with a median progression-free survival of 3.5 months and a median overall survival of 9 months. As is typical in trials of small cell lung cancer, for patients who had a short time of remission after their initial chemotherapy, they didn't do as well. So you see in the group of patients who had only less than 90 days from their prior chemotherapy, what we might have once called platinum insensitive or platinum refractory patients, the response rate was just 22% as compared to 45% for those patients who were what you might call platinum sensitive. And similarly, there was a longer median progression-free survival for that group with a longer chemotherapy-free interval. So just to summarize what I've talked about for small cell lung cancer, this is standard first-line therapy for small cell lung cancer is etoposide platinum with an immune checkpoint inhibitor. The anti-PD-1, PD-L1 antibodies that are FDA approved in this setting are atezolizumab and durvalumab. Both pembrolizumab and nivolumab have been explored in this setting. Both have reasonably suggestive data, but neither has shown a positive phase 3 trial yet. And so as a consequence, really in this context, durvalumab and atezolizumab are the appropriate agents. And then, of course, the data I just showed you shows that lurbinectedin is a new agent for treatment of patients with small cell lung cancer that has progressed after first-line therapy. We're going to move on next to non-small cell lung cancer. Non-small cell lung cancer, of course, we know that subtyping the disease is critically relevant. And for patients, we think about 2 different ways to subtype non-small cell lung cancer, or actually maybe 3 ways. Well, one is by histology, so squamous or non-squamous, by PD-L1 status, using immunohistochemistry, looking for patients who are PD-L1 high, PD-L1 low, or PD-L1 negative. And then we also look at a tumor mutation status. We look for mutations in genes like EGFR, ALK, ROS1, BRAF. And my next slide shows how we kind of incorporate that information to think of different discrete groups of patients that we approach differently in the treatment of their metastatic lung cancer. So for patients with metastatic lung cancer, we bring together histologic assessment, molecular analysis, and PD-L1 testing to really put them in three main bins. Patients who have a mutation or gene rearrangement, that's about a quarter of patients, we move towards targeted therapy for those patients. Patients with high PD-L1, who have PD-L1 greater than 50%, we have an approach for those patients that usually is able to not use chemotherapy and use single agent pembrolizumab or sometimes single agent atezolizumab. And then finally, this group is the group of patients who are less than 50% PD-L1, either low PD-L1 or PD-L1 negative. Just to remind you, this is what's referred to as the immunologic synapse. The space between an effector T cell and the tumor cell. You see that PD-L1 is expressed on the tumor cell and PD-1 is expressed on the T cell. The various antibodies that we talk about, pembrolizumab, nivolumab, atezolizumab, durvalumab, these all disrupt that interaction between PD-L1 and PD-1 and then allow the effector T cell to function and the cancer cell. This really came to the fore with this initial data for first-line therapy of patients who had high PD-L1. This is a trial that took untreated non-small cell lung cancer, so patients who had never had prior chemotherapy for their stage 4 non-small cell lung cancer, who had a PD-L1 tumor proportion score of 50% or greater. No patients with EGFR mutations or ALK rearrangements were allowed, and patients all had to have treated or absent brain metastases. Patients were randomized to either pembrolizumab or platinum doublet chemotherapy. This data came out initially in 2016. And you see here the progression-free survival curve showing a hazard ratio that was very impressive with a hazard ratio of 0.5, small p-value, and significant clear superiority for patients who received pembrolizumab rather than platinum doublet chemotherapy. Similarly, we've seen improvement in overall survival, and this is the most recent update of that data published last year. And this shows us that the hazard ratio for overall survival for those patients who received pembrolizumab was 0.63, and a really very impressive number. The median overall survival for patients who have PD-L1 high tumors who got pembrolizumab was 2.5 years. It still impresses me as we move forward to see such high median overall survival numbers, when I know when I got into this line of work, our average median overall survival on a trial first-line therapy was in the 10-month range. So we've made dramatic improvements with this, but clearly a lot further to go. These gains for outcomes with pembrolizumab are associated with fewer adverse events than we see with chemotherapy, but I think it's important to recognize that there are some special adverse events that we see in treatment with immune checkpoint inhibitors, and I'll just highlight some of those here. You look in the grade 3, 4, 5 column, that patients sometimes develop pneumonitis, sometimes develop severe skin reactions, colitis, hypophysitis, and then one that rarely makes it to grade 3 or 4, but one that's important to follow is thyroid dysfunction, with patients having both hypothyroidism and hyperthyroidism. So when we move on from that group of patients who don't have high PD-L1, who have PD-L1 scores that are either negative or less than 50%, we're guided first by this trial where people looked at the addition of pembrolizumab to chemotherapy. And so in the green here is the standard platinum plus pemetrexed, followed by pemetrexed maintenance. And in the blue is the intervention, which is that same chemotherapy backbone with the addition of pembrolizumab. Same sort of patient population in that they had no prior therapy for their non-small cell lung cancer, no EGFR mutations, no ALK gene rearrangements. In this trial, presented 2 years ago at AACR and published in 2018, we saw that the pembrolizumab combination, so patients who got platinum, pemetrexed, and pembrolizumab, had a marked improvement in overall survival with, again, a hazard ratio of 0.49 over the group that got just chemotherapy. So a significant improvement, and really established the role of combination chemotherapy plus immunotherapy as the standard first-line therapy for patients who had low or negative PD-L1. Just to remind you that even in patients who had no expression of PD-L1 in this, so this is a subset analysis of patients whose tumor was PD-L1 negative. Even in that population, there was a hazard ratio of 0.6, showing pembrolizumab combination was superior to chemotherapy alone. So I'm going to summarize a number of trials here with this slide and just remind you that chemotherapy plus immunotherapy quickly became the standard for patients with low or negative PD-L1, and there are a variety of choices for chemotherapy based on tumor histology. So the top 3 here have been studied in non-squamous non-small cell lung cancer: carboplatin, pemetrexed, pembrolizumab, which I just showed you; another regimen of 4 drugs: carboplatin, paclitaxel, bevacizumab, and atezolizumab; a taxane-based regimen for non-squamous with carboplatin, nab-paclitaxel, and atezolizumab. And then for squamous, there have been a number of regimens studied, but the one with improvements in progression-free survival and overall survival is the combination of carboplatin, a taxane such as nab-paclitaxel or paclitaxel, and pembrolizumab. So this really establishes chemotherapy and immunotherapy as the standard. So where do we build from there? So one thought is to go beyond just blocking the PD-L1, PD-1 axis, but in addition to block the CTLA-4 axis, and that's by using a combination of ipilimumab and nivolumab. And this is the data, this is the trial that has tried to explore that. It's a very complicated trial that we've seen presentations for at multiple meetings over the past few years, at least 2 New England Journal of Medicine papers out of this trial, and it's a little bit difficult to follow. What I'll highlight here, though, is there's 2 cohorts. There's PD-L1 high and PD-L1 positive and PD-L1 negative. So PD-L1 positive on the top and PD-L1 negative on the bottom. Those groups are analyzed separately. For the patients who are PD-L1 positive, there are 3 different arms for randomization. There's nivolumab plus ipilimumab, chemotherapy, or single agent nivolumab. For the patients who are PD-L1 negative, they were randomized to either ipilimumab and nivolumab, chemotherapy, or nivolumab plus chemotherapy. We don't have the nivolumab plus chemotherapy data here, so we're just focusing on the combination arm versus chemotherapy. So for the combination of ipilimumab and nivolumab, we saw improved overall survival compared with chemotherapy. So if, I think one thing that I should have mentioned as we were going through here, I think one of the key things as we led up to all these data is that we now know that the standard by which most new interventions should be judged is actually chemotherapy plus immunotherapy. So whether that's carboplatin, pemetrexed, pembrolizumab, or carboplatin, paclitaxel, bevacizumab, atezolizumab, we know those are the standards. But this trial was designed and executed before that became the standard, and so we're left with judging against chemotherapy. And so when we judge against chemotherapy, we see that ipilimumab and nivolumab is indeed an improvement, where we see approximately 7% improvement in 1-year overall survival and 7% improvement in 2-year overall survival, so that at 2 years, 40% of people are alive versus 33% in the group who got chemotherapy. This plot that I showed you is for the patients who are PD-L1 positive, so 1% or more, and this is the data for patients who are PD-L1 negative. Strikingly, this plot shows that there's a bigger spread between the group who got ipilimumab and nivolumab compared to chemotherapy in this group of patients who are PD-L1 negative. I think this is puzzling to a lot of people. A number of people have developed hypotheses around why that might be, but nonetheless, it shows us that again, it's an improvement compared to chemotherapy, and this shows us that it's not necessary to be PD-L1 positive to see benefits with the combination of ipilimumab and nivolumab. When you combine the 2 sets of data, we see this these survival curves, which really establishes that, again, nivolumab and ipilimumab is superior to chemotherapy alone. Again, not the control that we would have hoped for where we are today, but acknowledging when these trials were designed and executed, that was the appropriate control at the time. So one thing, if you're dropping out chemotherapy and moving to an immunotherapy only group, you think, well, maybe we're going to have less toxicity, get rid of that nasty chemotherapy. Unfortunately, immunotherapy does come with side effects, and in the group who got a combination of ipilimumab and nivolumab, in fact, saw higher rates of treatment-related serious adverse events in that group compared to the chemotherapy group. You see for grade 3 to 4 treatment-related serious adverse events, they're 18% in the ipi-nivo arm as compared to 10% in the chemotherapy arm. And similarly, treatment-related adverse events leading to discontinuation, we saw that 5% of the time, 14%, 9% for any grade for chemotherapy as compared to 18% for ipi-nivo. So somewhat more toxic, but nonetheless somewhat more effective. So after this data that we had going into ASCO this year, we really had these options. So if you had a high PD-L1, you could receive pembrolizumab. That was data I showed you. There's also some other recent data that's been presented showing that single agent atezolizumab has value in that context. For patients with low PD-L1, with the tumor proportion score of greater than 1%, there's another trial that shows single agent pembrolizumab may be appropriate, and there's an FDA approval in that context. I think most people wouldn't recommend that as a single agent. And then for patients with any PD-L1 status, and particularly those with PD-L1 negative tumors, the various combinations of chemotherapy plus immunotherapy, as well as ipilimumab and nivolumab. So going into ASCO, we had those as our options. And when you look at this list, probably the thing you didn't say we needed is one more chemotherapy plus immunotherapy option. But that's what we saw at ASCO. We saw the combination of ipi-nivo, but instead of just ipi-nivo, we added some chemotherapy to that. And again, the control arm in this trial was chemotherapy alone. Now, this is a trial that allowed patients with metastatic lung cancer, no prior therapy. Both squamous and non-squamous histology tumors were allowed. And so the chemotherapy for those patients who had squamous tumors was paclitaxel plus carboplatin. And for the patients with non-squamous non-small cell lung cancer, they received pemetrexed along with cisplatin or carboplatin. In the control arm, they received 4 cycles, and if they had got pemetrexed, they went on to maintenance pemetrexed. In the intervention arm, they got nivo-ipi, and then just 2 cycles of standard chemotherapy. And the idea was to improve outcomes for ipi-nivo by adding a couple cycles of chemo to it, though that's not what we're testing here. We're just comparing to standard chemotherapy alone. This is the overall survival curve we saw presented at ASCO this year. You see real improvements compared to the backbone of chemotherapy alone with the combination of chemotherapy for 2 cycles plus ipi-nivo. You see the improvement in median overall survival from 10.9 months to 15.6 months, hazard ratio of 0.66. And the benefits were present whether you got the non-squamous chemotherapy regimen for patients with non-squamous non-small cell lung cancer, or you got the carboplatin paclitaxel regimen for those patients with squamous cell non-small cell lung cancer. I will highlight that if you went back and stared at all the slides that I showed you for the comparison between ipilimumab and nivolumab compared with chemo, so not combination arm, we saw very similar 12-month overall survivals. Now, it's cross-trial comparisons, so those are always risky, but it's nonetheless a very interesting similarity in the outcomes. We saw benefit across PD-L1 status, so PD-L1 negative tumors as well as PD-L1 positive tumors with a very similar hazard ratio. So I showed you this long list before. The long list is slightly longer with the addition of an opportunity for ipilimumab, nivolumab, and 2 cycles of chemotherapy, such as carboplatin paclitaxel for patients with squamous cell non-small cell lung cancer. So this is one more thing to add to our potential list of treatment options. So we'll move now from the immunotherapy-based approaches to targeted therapy-based approaches. So I think it's really critical that we acknowledge that when we meet a new patient with non-small cell lung cancer, critical part of evaluating that patient is a thorough molecular analysis to identify any driver oncogenes in that patient's cancer, because that really provides an opportunity for targeted therapy as initial treatment for that patient, which is been clearly shown to be improved compared to chemotherapy, and has a higher response rates even compared to immunotherapies in those contexts. Again, this represents about 25% of patients with non-small cell lung cancer. So this is a kind of a classic pie chart that we often show when we think about patients with lung cancer, and this shows the distribution of various oncogenic drivers. You see at the top is the EGFR sensitizing mutation, which occurs in about 24% of patients with non-small cell lung cancer. And then we see a long list of less common things, but important to identify: patients who have ALK gene rearrangements, ROS1 rearrangements, BRAF mutations, and NTRK gene rearrangements. You notice here that NTRK, it rounds down to 0% in my Excel graph, because the frequency of NTRK rearrangements in patients with lung cancer is less than 0.5%. But nonetheless, identifying all of these is important. Between ASCO this year and a couple recent meetings and recent approvals, we've now expanded the list of key molecular subtypes that we need to identify in our patients with non-small cell lung cancer, and we've really added MET exon 14 and RET gene rearrangements. So let me take you through some of that data. So MET exon 14 alterations are interesting mutations in that they're not mutations that lead to an actual change in the protein. They just simply lead to greater stabilization of the protein by skipping this particular exon of the MET gene. The protein becomes more stable and allows that protein to signal more. And you'll see that in this next slide. This is an example showing of MET overexpression by protein in most of these patients who have MET exon 14 alterations. We first saw that you could target MET exon 14 with this trial led by my colleague Alex Drillin, where he showed that patients who have MET exon 14 could have a response to crizotinib. Unfortunately, the response rate for crizotinib in this context was less than 40%, and the median progression-free survival was relatively short, approximately 6 months. So that left open an opportunity for other MET inhibitors to be explored. This is capmatinib. This is the trial design for a capmatinib trial that looked at capmatinib in patients with MET exon 14 skipping. So this is a group of patients with stage 4 non-small cell lung cancer who had MET exon 14 alterations, and they could have had prior therapy. And if they had prior therapy, they went into cohort 4. And if they had no prior therapy, they went into cohort 5B. Numbers aren't relevant, but I'll show you that there is a difference in outcome for these patients. From the waterfall plots presented at ASCO last year and the recent package insert, we have this data that show for, on the left, patients who have previously treated MET exon 14 positive non-small cell lung cancer. There was a response rate of 41%. And on the right, patients who had upfront treatment of their MET exon 14 positive non-small cell lung cancer with capmatinib, the response rate was 68%. I think it's really important to look at this and see those differences in response rates for first line versus second line, and remind ourselves that it's important that we identify these driver oncogenes in the first line setting so we can give our patients the best chance for response to these targeted therapies. And as a consequence of this data, this drug capmatinib was recently granted accelerated approval for patients with metastatic non-small cell lung cancer with MET exon 14. And then at ASCO this year, we saw data on a new drug. This is a drug called tepotinib. This was presented at ASCO and also co-published in the New England Journal of Medicine. This trial was led by my colleague Paul Pack. And you see from this waterfall plot that the vast majority of patients had a good response to therapy. One thing that I like about this set of data, it's actually when you stare at this waterfall plot a long time and look at the various graphs, it really conveys a lot of information. I'll highlight two things really. One is that patients in the trial, at the very bottom, you see that they all had received, first line, second line, third line. So there's a wide range of lines of therapy incorporated here, and you see that again, the first line therapy patients probably had better responses, deeper responses than the second and third line therapy patients. So again, we should really be identifying these upfront. And then also in the top, you look at the objective response rate and you see there's three different categories. There's combined biopsies, liquid biopsies, and tissue biopsies. I think what's relevant here is this is one of the first studies that we've looked at where patients could have enrolled based on the result of, quote, liquid biopsies. As my friend Bruce Johnson says, a liquid biopsy is not a biopsy, it's a blood test. But it nonetheless gives us information about a tumor that we used to only get from doing a tumor biopsy. So using liquid biopsies or tissue biopsies, they were able to identify patients with MET exon 14 and see very high response rates of 45 to 50% for these patients. So we'll move on now from MET exon 14 to another new category, which is RET gene rearrangements. You heard a little bit about RET from Dr. Sherman earlier, and this is, we've seen a similar big change in patients with lung cancer with similar drugs. I'll take you through the data with a drug called selpercatinib. Selpercatinib is a very specific RET inhibitor, and it's been studied in patients with RET-positive non-small cell lung cancer. This is a nice waterfall plot, again, showing lots of different data, but I'll highlight here that the overall response rate in this whole cohort was 68%. And importantly, even in those patients who had CNS metastases, the response rate was very high, with a response rate of approximately 90% in those patients who have CNS metastases. So really demonstrating that selpercatinib is an effective drug with a high response rate, but also that it can penetrate the CNS and treat CNS tumors. One thing that we find frustrating about some of our targeted therapies is the progression-free survival, the duration of response. For a first RET inhibitor, this drug, selpercatinib, has a very impressive median progression-free survival of 18 months. So this is patients who had first line, second line, third line selpercatinib. We saw a median progression-free survival of 18 months, which is really on par with what we see for first line therapy in patients with EGFR mutant lung cancer with this drug called osimertinib, which took us a long time to get to. So I'm really impressed by the outcomes with selpercatinib for patients with RET-positive lung cancer. Really reminds us that we need to test for this. So this is where we are today in looking for patients with metastatic non-small cell lung cancer. We need to look for EGFR, ALK, ROS1, BRAF, RET, MET exon 14, and RET's so important I put it twice on the list, and NTRK. And just a reminder that you need to test for these or you won't find them. We do have newly approved drugs in this space with capmatinib for MET exon 14 and selpercatinib for RET rearranged non-small cell lung cancer. I just wanted to take a second and highlight some data we saw at ASCO about another new target. If you look on this pie chart between MET exon 14 and RET, there's ERBB2, which we all know of as HER2, which we often think about in breast cancer, but it's mutated about 2% of the time in patients with non-small cell lung cancer. And some data we saw at ASCO this year really impressed upon us that we can target this potentially. The data we saw at ASCO was made using this data, or this drug, trastuzumab deruxtecan. Trastuzumab deruxtecan is one of these new antibody drug conjugates. We don't have too many of these antibody drug conjugates in the solid tumor world, but this is a highly evolved form of trastuzumab antibody drug conjugate where you've probably heard of other antibody drug conjugates, but this one really has a very high drug to antibody ratio. So more toxins added to the antibody to hopefully make it a more potent killer of those cells that it binds to. And trastuzumab deruxtecan actually was first studied, of course, in breast cancer. And this is a paper published by my colleague Shinu Modi, where she looked at trastuzumab deruxtecan in patients with previously treated HER2-positive breast cancer. So this is breast cancer data. And remember, in breast cancer, HER2 is amplified. Lung cancer, it's mutated, but I think it's important to recognize that. So these patients in this study for breast cancer had previous therapy with trastuzumab, as well as trastuzumab and tansine, as well as and they could have had other HER2-directed therapies. But despite these prior treatments with other HER2-directed agents, the vast majority of patients had significant tumor shrinkage with trastuzumab deruxtecan, showing us that this is can be an effective therapy in that context for patients with breast cancer. And at ASCO, we saw data looking at lung cancer. But before I get to that, I should remind you from the black box warning in the FDA approval for breast cancer that there's a somewhat important adverse event called interstitial lung disease or pneumonitis. We often see pneumonitis with a variety of drugs, but this seems to be a bit more common and a bit more concerning and something to know about if you're prescribing trastuzumab deruxtecan. And I'll mention that in just a moment as we go through the data in lung cancer. So at ASCO this year, we saw data for trastuzumab deruxtecan in patients with HER2 mutated non-small cell lung cancer. And this is one of those waterfalls that I think investigators always are hoping for, where essentially every single patient's tumor shrank. There's nobody whose tumor grew on this waterfall plot. And to me, that's an impressive phenomena. You see the overall response rate by independent review was 61.9%, showing that that in addition to almost everybody's tumor shrinking, most of them met the resistive definition of response. And again, a median progression-free survival, which is the thing I think most of us care about when we're treating our patients, is 14 months, meaning that on average, 14 months from the start of this therapy, patient's disease was controlled. So I think it's really an impressive result, and heralds a new opportunity for our patients with lung cancer in that this is essentially the first antibody drug conjugate for patients with non-small cell lung cancer. I mentioned interstitial lung disease as the black box warning for trastuzumab deruxtecan. They did see that in this trial of patients with lung cancer. So among the 42 patients with lung cancer, 12% of them had grade 2 pneumonitis. It's important to recognize that in this trial, the investigators were tuned in to the issue of pneumonitis and were closely watching and interrupted treatment early and gave steroids and were able to manage the pneumonitis for these patients. Importantly, no grade 5 interstitial lung disease was reported and not even any grade 3 or 4. So it seems like as long as investigators are aware of this side effect, it can be managed. So I think perhaps we will add HER2 mutations to this long list of targets that we need to know about for our patients with metastatic lung cancer. So in my last section, I want to talk briefly about how we can incorporate targeted therapy into another place in the approach to treating patients with lung cancer. This is a diagram I use when I talk to fellows about how we treat lung cancer. I note that in stage 1 non-small cell lung cancer, we treat with surgery and sometimes radiation if the tumor or the patient is inoperable. If similarly in stage 2, we would typically do surgery. Sometimes we add some chemotherapy. In stage 3, we'll do surgery, or sometimes we'll do radiation with chemotherapy. And if we do chemotherapy radiation, then we'll use immunotherapy post-chemo RT. But it's only in the stage 4 or metastatic or recurrent disease section where we have all of these newer therapies, including targeted therapy. Nowhere else has targeted therapy been shown to be useful in patients with lung cancer. Perhaps that is until this year at ASCO. At ASCO, I will remind you guys a little bit about the optimal treatment of patients with metastatic EGFR mutant lung cancer. So upfront treatment of EGFR mutant lung cancer was really governed by this trial, which was reported out a few years ago, and we've seen recent updates with survival. And this is a trial of newly diagnosed EGFR mutant non-small cell lung cancer. Patients are randomized to either osimertinib or gefitinib or erlotinib. So the standard EGFR TKI, gefitinib, erlotinib, or the third generation EGFR TKI, osimertinib. Primary endpoint for the trial was progression-free survival, but another endpoint was overall survival. In 2017, we saw a presentation of the progression-free survival data showing us that osimertinib was superior to standard EGFR TKIs with a median progression-free survival of 19 months compared to 10 months in the group who got the standard EGFR TKIs. And then more recently, last year in New England Journal of Medicine, we saw a publication of the overall survival data showing that this improvement in progression-free survival then translated into an improvement in overall survival, with a median overall survival for those patients who received osimertinib of a little over 3 years, which is, again, a very impressive achievement in treating this subtype of non-small cell lung cancer. We clearly need to be better than this, but it's the best outcome for EGFR mutant lung cancer that we've seen in a while. But I will remind you, I'm going to next go into early stage data, but with a median overall survival with osimertinib in the stage 4 non-small cell lung cancer setting of over 3 years, exploring drugs in the early stage setting is a little bit more complicated because it's going to take a lot longer to see some of the outcomes that we're interested in. As a consequence of this data for first-line therapy for patients with EGFR mutant lung cancer, the preferred first-line therapy is osimertinib. Some of the other drugs that we talked about, erlotinib, gefitinib, as well as afatinib, dacomitinib, and even the combination of erlotinib and ramucirumab are also options for treatment of patients with EGFR mutant lung cancer. So now we're talking about the early stage setting. So I'll just remind you that for patients with non-small cell lung cancer who have early stage disease and undergo tumor resection, outcomes are not great. You know, even for the earliest stage patient with a stage 1A tumor, there's about 15 to 20% of those patients end up having recurrent disease and die from their cancer within 5 years. And if you get a little further down in stages to stage 2 and 3, more than half of patients die from their cancer within just 5 years. So clearly we have a long way to go to improve outcomes for patients with early stage lung cancer. And we have to think of a variety of approaches. And one of those approaches is to incorporate targeted therapy. So this is data presented at ASCO this year that looked at treatment with osimertinib in the adjuvant setting. So just to go through the trial criteria, so this is patients who had stage 1B through 3 non-small cell lung cancer, who had surgical resection, and they were allowed to receive adjuvant chemotherapy before study entry. And then patients were randomized to either placebo, which would be the standard of care at that time, or osimertinib, 80 milligrams once daily for 3 years. Important to remember that duration of osimertinib is 3 years. The primary endpoint of the trial was disease-free survival in the particular subset of patients with stage 2 and 3A tumor. This is the data we saw at ASCO. We saw an improvement in the disease-free survival in patients with stage 2 and 3 disease, where you see at 2 years, the disease-free survival for that group of patients was 90%. For patients who got osimertinib as compared to 44% for those patients who got placebo. Looking at the groups of patients enrolled, it's important to notice which groups seem to do the best. And if you look at the hazard ratio for stage 1B, you see the hazard ratio is 0.5, and you see very impressive hazard ratio of 0.17 and 0.12 for those patients with stage 2 and 3. So showing us clearly there's a disease-free survival benefit that's much more dramatic for those patients with later stage disease, those patients who are more likely to have recurrent and progressive disease. One thing we'd love to see is more overall survival data. They did show an early snapshot of overall survival, and you see that it trended towards improvement in patients who received osimertinib, but it's an extraordinarily small number of patients who've had recurrence. Because I'll just remind you back to what we were talking about earlier, that in metastatic non-small cell lung cancer, the median overall survival for patients with EGFR mutant disease who received first-line osimertinib is over 3 years. So in this group of patients with early stage disease, we wouldn't expect those patients to have recurrence and progression and death in such a short interval of follow-up. So this is a provocative early data in terms of overall survival. For a drug that you're going to give to patients for 3 years, it's important to look at the toxicity profile. You see that the most common toxicities are the ones we expect in patients who are receiving EGFR TKIs, things like diarrhea, paronychia, dry skin, but there were only rare grade 3 and grade 4 events. Before we go on, I just wanted to point out that use of EGFR TKIs in the adjuvant setting is not a new concept, and this is actually explored a number of years ago and presented at ASCO 2014 and later published in 2018. And this is using erlotinib as adjuvant therapy, but in this context, patients stopped erlotinib after 2 years. But I just remind you that there was much ado made of the osimertinib disease-free survival at 2 years, and you see it's 90%. Yes, that's a very impressive number. But if you look at this trial from long ago, where patients received erlotinib for just 2 years, the disease-free survival at 2 years was 90% as well. Now, you recognize that when patients stopped the adjuvant erlotinib at 2 years, then they continued to recur, and there was a significant increase in disease recurrence rate. So it's something to pay attention to and something to enlighten how we interpret the data for adjuvant osimertinib. So I think these are some of the questions I think that'll come to mind when we think about the use of adjuvant or postoperative osimertinib. So what's the best population to receive it? I think we see the data that show the later stage disease is probably the right group of patients to receive it. Does it cure people or only delay progression? I think that's an important question, and I think we don't have the data yet to know the answer. Some people ask, does that matter? If isn't delaying progression a benefit in and of itself? And I think that's certainly a conversation you have to have with patients. But it's particularly challenging when you think about signing up for a 3-year course of a medicine. And then finally, I think the question we all have is, will it improve overall survival? And we don't know that, but it's something that we look forward to knowing more about, and we'll see further data on this. So just to conclude, immune checkpoint inhibitor plus platinum etoposide remains the standard of care for patients with extensive stage small cell lung cancer. A short course of chemotherapy with ipilimumab and nivolumab is another option for patients with stage 4 non-small cell lung cancer who don't have an oncogenic driver. We've learned about new targetable oncogenic drivers, including MET-exon 14, RET, and HER2 mutations. And then finally, I think we can now start to consider the use of EGFR targeted therapy in the adjuvant setting. Before I go on and take questions, which I hope to do, I just wanted to take 1 second to take a tangent to talk about COVID-19. I work in New York City, where COVID-19 has been a huge problem, one that we've dealt with hundreds and hundreds of patients in our hospital, and it's been transformative for how we take care of patients for us, and I'm sure for you as well. But I did want to remind everybody of one little statistic. So this is 11%. This is like the Harper's Index or those various stats. So 11%, what is that? And that's the number of patients who died from COVID-19 in our series of patients with lung cancer. This is a paper published just earlier this week in the Annals of Oncology from our group. We looked at all of our patients with non-small cell lung cancer, and we looked at the peak COVID time from mid-March till May, and we looked at what proportion of our patients died from COVID-19. Of all the deaths, 89% of those patients died from complications of their lung cancer. Just 11% died of COVID-19. So COVID-19 is a big problem, one that we need to do our best to manage the spread of, or at least control the spread of. But getting back to treating patients with cancer is just as important. And I think it's something for us to always remember as oncology professionals. So I'll stop there, and happy to take any questions.
Thank you, Dr. Riely. And we do have a few questions that came in through the chat box. The first one says, with multiple options available in PD-L1 low or negative patients, what is your preferred therapy, chemo immunotherapy or immunotherapy?
I'll tell you honestly, I typically do chemotherapy plus immunotherapy as my initial approach, and I think, I think when you meet a new patient and you think about the toxicity profile, carboplatin plus pemetrexed plus pembrolizumab is a very reasonable regimen that seems to offer very similar benefits to what we see in patients who received ipilimumab and nivolumab. I've had a little bit more experience with that approach, and so I feel comfortable with it. But I think it is something that we're going to explore a bit more and hope to see more data on that.
Okay. And then we do have another question. RET, MET, BRAF, should I check for those in squamous histology?
Yeah, so I think this is a really important question because right now, for instance, the NCCN guidelines and many organizations recommend that we mainly test patients with non-squamous histology tumors. I think there are a couple troubles with that. One is I think that most times when we diagnose non-small cell lung cancer, it's a diagnosis based on a tumor biopsy. A tumor biopsy by its nature is a small biopsy, meaning you don't get a full sample of the tumor. And when we biopsy a tumor that has a small component of squamous cell, we could be missing an adenosquamous tumor, and that's a tumor that often has some of these mutations like RET, MET, and BRAF. And I will highlight there was a poster at ASCO that looked at MET exon 14 frequency in patients with a resected squamous cell. So a resected tumor where the pathologist had as much material as they wanted to look at, and they decided it was a squamous cell tumor. They still found MET exon 14 alterations in about 2.5% of those tumors. So I think this is something we need to really get away from. And I think I would look to test all of them. I test all my patients with non-small cell lung cancer, whether they have squamous or non-squamous histology tumors.
Okay, we did have another question come in. Is there any evidence of synergy adding immunotherapy to targeted therapies as we do in chemoimmunotherapy?
I think it's a great idea and one people have explored. Unfortunately, we've run into very unexpected toxicities. So I'll start with the first part, which is that immunotherapies don't typically work so well in oncogene-driven lung cancer. So we have data in EGFR mutant lung cancer, PD-L1 expressing EGFR mutant lung cancers. The response rate to single agent pembrolizumab is 0%. And that's in small series, so you can imagine that data might be slightly higher with larger groups. But when you compare that to like 70% for EGFR TKIs, it's very clear that the TKIs have much better outcomes than immunotherapy alone. But what we would love to do is to combine these drugs. Unfortunately, in the first data combining osimertinib plus durvalumab, we saw an unexpectedly high rate of pneumonitis. About a third of patients developed pneumonitis, making it sufficiently toxic that we wouldn't want to do that combination. And in fact, even when you sort of incidentally do that combination by giving an immunotherapy such as pembrolizumab and then switching to osimertinib, where that pembrolizumab is still in the patient's system, we sometimes observe unexpected toxicities. There's been one trial where they combined erlotinib and atezolizumab, and they didn't see unexpected toxicity, but they also didn't see any real benefit. They didn't see an improvement in progression-free survival, improvement in overall survival. So as a consequence, I think people feel like that's not an approach that's really going to lead to a lot of improvement.
Do we have any other questions for Dr. Riely? All right, Dr. Riely, thank you so much.
Thank you.